Good evening, everyone, and welcome to yet another COVAX webinar. Our speaker today is unique in many ways. Our guest actually today is unique in many ways. She is an avid researcher and a physician, a pathologist. Her sense of perseverance, love of knowledge, and intelligence to venture new intellectual realms are quite remarkable. If I were to put it in
toys on the ground.
Excuse me? Okay, I'm going to mute all. هأرجع أعيد. Okay? So sorry for that. Mute all attendees. Okay, so I'm going to introduce. Our speaker is unique in many ways, as I said. I know her to be an avid researcher and a pathologist. She has a remarkable sense of perseverance, love of knowledge, and intelligence, which allows her to venture new intellectual realms beyond imagination, actually. So if I were to say one statement about our speaker today, I would say the sky is her limit, if at all. And the love, respect, and support that her colleagues at King Hussein Cancer Center have for her is quite impressive and very well deserved, if I may. She was the first one to venture introducing bioethics at King Hussein Cancer Center in Jordan and partnering with the Salim Al-House Bioethics and Professionalism Program on an adventure, actually on a number of adventures that were not sure to succeed, but under her superb leadership, they were actually a huge success. So I'm officially now introducing Dr. Maysa Al-Husseini, a colleague and very dear friend who is a consultant and full member at the King Hussein Cancer Center in Amman, Jordan, and chair of the IRB at the King Hussein Cancer Center. Dr. Maysa graduated from Jordan University Faculty of Medicine and trained initially at the pathology department at Jordan University Hospital. She is currently a full member and a consultant histopathologist and neuropathologist. She is a past president of the Arab Division of the International Academy of Pathology from 2017 till 19. She has also been chair of the Research Ethics Committee at the King Hussein Cancer Center since 2008, as well as the acting manager of the Human Research Protection Program Office since 2018. Quite a big load, actually. In September 2019, Dr. Maysa earned her CIP credentials by passing the examination of the American Public Responsibility in Medicine and Research, and she became the first Jordanian CIP member. She has more than 100 publications in peer-reviewed international journals, as well as 5 book chapters.
Dr. Arawi, I think you're muted بالغلط.
Okay, when did you stop hearing me?
100 publications.
Yes.
Okay. Okay, so she has 100 publications, actually more, in peer-reviewed international journals, as well as 5 book chapters, including chapters in research ethics and the Arab region. In addition, there are several publications related to bioethics, including an appraisal of the Jordanian stem cell law in relation to international laws, and in view of the framework by the Global Alliance for Health and Genomics. Other publications include the views of Jordanian cancer patients on the potential use of surplus tissue in research and tissue archived in biobanks, which is an extremely interesting study. Recently, Dr. Maysa became a guest associate editor of the very special topic, Bioethics Amidst the COVID-19 Pandemic, along with a few guest editors, and she has contributed several articles to the special topic. And this is in a journal entitled Frontiers. She is an invited speaker at national, regional, and international conferences in research ethics and applicable local and international regulations. She tutors graduate students and professionals through holding workshops in research ethics and applicable laws and regulations in collaboration with SHBPP at the UBMC, and often holds amazing grand rounds and seminars. So without further ado, thank you very much, Maysa, for joining us, and the floor is yours.
Thank you very much, Talia, for the invitation and for giving me the chance to be among the very special and eminent speakers that you choose actually very carefully in the COVAX webinar series. I would like to thank everybody who took the time out of their afternoon, perhaps relaxation hours, to join the webinar. And as we are witnessing actually the COVID-19 pandemic, and as was mentioned by Talia, we held a special together actually with Talia, Dr. Asim Mansour, colleagues in Canada and in the States, special issue on bioethics amidst the COVID-19 pandemic. Actually, it's almost a year now since we started working on the proposal, and it's almost an excess of 10 months when we started actually receiving the proposals and the manuscripts. So I'll be today talking about a very important topic that perhaps we've been hearing about since the start of the pandemic until the current day, which is the allocation of scarce medical resources, whether this is in the form of ventilators or vaccines or others. So just a quick overview. We know that for the past 20 years, we have been actually, the world has witnessed three major infections by coronaviruses that amazingly have crossed the species-specific boundaries and led to infection, in particularly pneumonia in humans. So from the SARS-CoV that started early in after 2000, including the H5N1 and H1N1 influenza to MERS, and the more recent encounter, which is the SARS-CoV-2 infection. And just quickly to remind everybody that this is an RNA virus that has a special composition where we have the nucleocapsid, we have the cell membrane, and we have the spike proteins, which are important in infection, and actually many of the vaccines are directed against different domains within the glycoprotein as well as the membrane protein. And common features to all coronaviruses that have been witnessed over the last 20 years is the tendency to cause lung injury that usually manifests in the form of acute respiratory distress syndrome, leading to hypoxia, hypoxemia, leading to eventually to pulmonary failure, which can be fatal. Now, on the 11th of March 2020, the WHO declared COVID-19 as pandemic. And since then, we have been witnessing an increased number of people infected, affected, perhaps dying as well as a consequence of being infected. And this is actually a couple of days old figures that look into the total number of cases thus far. This is on the 22nd of March, 124 million cases plus cases that have been infected with COVID-19. Out of these, there are a total of 21 million plus active cases. It has caused 2,700,000 plus deaths, and currently there are at least 90,000 plus almost 91,000 cases that require being admitted to the critical care. And when we look at the case distribution per country, we see that almost a quarter of cases have aggregated in the States, but other countries, including Brazil, India, the United Kingdom, Russia, many countries in Europe have been affected severely by with increasing number of infected cases. Now, I tried to locate both our countries, Jordan and Lebanon, And what we contribute to the world percentage of infected cases is almost 0.5% in Jordan and 0.4% in Lebanon. And whenever we talk about coronavirus and the COVID-19 pandemic, there are 4 V's. I group them, try to be sort of creative, group them under the a common theme of that they share almost, they all share V somewhere within the names or within their features. So when we started, when the coronavirus pandemic started, everybody was talking about ventilators and some vital items, including the face masks, the shields, the PPEs. And then we moved into antiviral treatments, and more recently, everybody is talking about vaccines. So these are essentially the 4 major medical resources that have been utilized and are in continuous need for under this pandemic. And certainly bioethics amidst the COVID-19 pandemic will be revolving around one or more of these items. So it will be almost always the allocation of or access to resources that are typically perhaps not very much discussed in luxury times, but in the pandemic, in the current pandemic, this is becoming really a topic of everyday talk. And if we just allude into a few of these examples, at the very start of the pandemic, everybody was talking about ventilators. And just to give you a sense of the increased demand or increased need for ventilators, so it was estimated in the pre-pandemic period that almost the world needs 80,000 new ventilators. However, when the pandemic hit in New York, it was estimated that New York itself alone will need something like 30,000 ventilators, and which that translated into a weekly need of in excess of 800 to 900 a percentage of what was produced in similar times, or even the capacity of the different manufacturers to produce and to be able to provide to consumers. And if we look globally, actually, what was needed at that time is scaling up the production of ventilators by at least 1,100%. And this was a depiction of the production growth for ventilators in the USA. And you can see the upward trending as the pandemic was revealing its faces. Now, when we look into the globally, there were so many articles and editorials discussing the world need for ventilators, and that at least 10 times the need amounts to at least 10 times what is available actually in the market. And some people went a step ahead and said, perhaps we should try to think more practically. Perhaps in order to be able to meet the demands in the market, we should try to design and test for some affordable and easy to build non-invasive ventilators. They will not be the top-notch ventilators that are utilized in the different ICUs in better resource countries, but at least this can counteract the deficiency and the scarcity of those very important instruments in less resourced countries. Now, when it comes to vaccines, actually, as of the 23rd of March, of yesterday, at least 70 vaccines are really present or are run in clinical trials. 23 vaccines have reached into the final staging of testing, and 77 are in preclinical stages. What is really approved and being utilized nowadays within the markets is only 7 approved vaccines. Now, if we look into the world map distribution of the vaccine utility, availability and utility of the vaccine, now the darker the merrier, the darker green, the better. So we can see that there are only a few countries, actually. It's the States, Chile, the UK, Emirates, and somewhere here is, this one here is Israel. So actually, those countries are the only ones that have, in a way, been able to provide what looks like to be an adequate number of shots of vaccines to their population. But look at the map for the rest of the world. Certainly not everybody is catching up. And then there was this question, when will life return to normal in view of the vaccine, of the availability of the vaccine? And the answer came as it would take years. It would take years for providing a global immunity if the pace will be going on with the same rhythm for the rest of the world, for the rest of the coming few months or weeks to months. So it seems that there will be a huge demand and a huge request for vaccines as we go on with the pandemic and revealing its different phases. So back again into our 4 V's, the ventilators, the vital items, viral treatments, and vaccines. Now, when we talk about bioethics amid the COVID-19 pandemic, and when we talk specifically about the allocation of the scarce resources, the scarce medical resources, we have to ask ourselves a few questions. Who gets to decide who gets the ventilators, the vaccines, or the medications? Would we consider patients with chronic illnesses, with cancer, for example? Would we prioritize physicians, perhaps the public, vulnerable population? Can COVID-19 patients compete with other patients for same resources? And who gets to determine who gets what? And what are the principles that would govern the allocation of the scarce resources? Now, I'm going to share with you, actually, this is the outline of the coming part of my lecture. I'll be alluding into the ethical principles that guide the allocation of resources and how to prioritize who gets what. And then, can the same frameworks and guidelines work in well-resourced as well as the poorer or low-resourced countries? Now, when it comes to the principles of allocation of scarce medical resources, there are several theories of the distributive justice. Something that is called utilitarian, أو المنفعة أو النفعية, egalitarian, which is المساواة, and then prioritarian, which is according للأولوية. A very nice article, actually, that was published in Lancet in 2009, looked into the frameworks or the principles of allocation of scarce medical resources. Now, in particular, this article was like a theoretical framework that hypothesized deficiency or scarcity of organs for donations as well as vaccines. Now, of course, we know that donation of organs is an ongoing, debatable process when it comes to the allocation of a very limited resource. However, the vaccine, in particular in this article, was actually hypothesized to be during a pandemic situation. They discussed 8 simple allocation principles that were further classified into 4 categories. Now, the first category was treating people equally, or what is known as the egalitarian theory. And in that, under this umbrella, we have 2 allocation principles, lottery and waiting list. The second category is favoring the worst off, which is known as the prioritarian theory. And under this theory, we have, or under this framework, we have 2 principles, sickest first and youngest first. The third category is maximizing total benefit, or the utilitarian. And under this, we have 2 principles, the number of lives saved and prognosis. And the last was promoting and rewarding social usefulness, which is sometimes referred to as social welfare. And under this are two principles, which are instrumental value and reciprocity. So to try to understand or dig deeper into the meaning of each and every one of these, when we talk about lottery, it's random allocation. So a number of people would be present in need for a scarce, one of the scarce supplies, and then you just were going to choose randomly this person or that person. However, the main disadvantage of lottery is that it tends to blind or ignore many important and relevant factors, for example, prognosis or age of the individual. In the waiting list, actually, what we know as the first come, first served. So some ethicists would consider this as a natural lottery. And again, waiting list tends to ignore important differences between people. And it's known that in some cultures or in some countries, waiting list can be manipulated. So those with sort of some form of symbolic or literal importance can be pushed to the front line. And so they will become the first in the waiting list rather than returning their real number or location or rank within the list. Now, when we talk about favoring the worst off, we talk about two principles, sickest first. So this criteria is very important. This is actually what physicians use most often in daily practice. Now, imagine if in emergency room, two patients walked in, one with an MI and one with severe pain. The physicians will give the priority to the patient who's sickest, whose life might be in danger, and so they will prioritize the patient with MI over the patient with severe pain. However, this principle tends to ignore post-treatment prognosis. What would be the outcome, the ultimate outcome of the patient? Now, youngest first is very simple. So this is given, the priority is given to patients who are younger among the different types or the different group of patients. The main disadvantage is that it does not really put a boundary to the age. So if we take it just literally as is meant, then infants and young children will be prioritized over perhaps youth, adolescents, or young adults. When it comes to maximizing total benefit, there are two principles: the number of lives saved versus the prognosis. And this is simply can be stated as we either give a few life years to many or give many life years to a few. This is how we make the prioritization. Now, promoting and rewarding social usefulness, again, is very interesting. So we look into two things, instrumental value and reciprocity. And instrumental value is kind of forward-looking. So we anticipate that giving the scarce resources to this group of individuals would be of benefit to the whole society. Like what happens really now with the vaccination, the priority was given or should have been given to physicians, because if they feel well, if they are protected, then this will be reflected on the rest of the population. Reciprocity is actually completely the opposite. It's backward looking. So the priority should be given, according to this principle, to patients or participants who have done something good, who have volunteered in the past. For example, those who donated their organs sometime in the past, so who did something good in the past. However, the main disadvantage is that it's really time consuming to go over the list of people who have volunteered their time and effort sometime in the past in order to give them to be prioritized. Now, at the end of this very important article, the authors came into conclusion that no single principle is sufficient to incorporate all morally relevant consideration, and therefore, individual principles must be combined into multiple principle allocation system. So in other meaning, we should not really stratify individuals based on single allocation principle. Perhaps we should look into ways where we can combine many of those principles into something that is more meaningful. Very important conclusion that came out of this paper is to the authors, and remember this was theoretical, a framework. Most principles were considered to be fair except for waiting list and sickest first principle. According to the authors, these were considered unjustifiable, not morally acceptable, and so they were rejected as principles for allocation of resources. Now, a few years later, another paper appeared in PLOS One in 2016 that really wanted to answer these two questions. Are really waiting list and sickest first principles unethical to be considered? Now, the approach that was taken by the authors in this paper, that they compared 10 ethical principles, and this time they went and looked into they surveyed 4 groups of individuals, including lay people, general practitioners, medical students, and other health professionals. And the 10 allocation principles are more or less the same. They've added monetary. And the monetary principle simply says that if you can contribute to a part or the total of your of the scarce medical resource, then perhaps you should be awarded or you should be given a priority. Another important principle depended on combination of different criteria. For example, the youngest first and the waiting list. So they combined several scenarios or principles and tried to see if people would choose combination criteria rather than just one principle of allocation. Interestingly, what did lay people say? Lay people rated sickest first and waiting list on top of all allocation principles. So it's quite opposite to the framework that was initially proposed. On the contrary, they thought that lottery, reciprocity, instrumental value, and monetary contribution are very unfair. So in order to understand how these systems work, we need to slightly understand how prioritization systems work. And apparently there are 2 different systems, a system that is based on single point system and systems which are based on multiple principal priority scoring system. And an example, this is an example about vaccination. This is prior to COVID-19 pandemic. And according to the CDC, they thought that vaccine allocation guideline should be placed on 4 tiers. So those who provide homeland and national security are top priority. Providing healthcare and community support services come next. Maintaining a critical infrastructure like physicians, for example, come third. And being a member of general population would come fourth. Now, when we could, another example of the multi-step or multi-principle allocation system is just like a scoring system. So we have different criteria or different principles with different scores, and the patient will be allocated the score of each principle according to the status, to the health status, and then there will be a final score according which the decision for prioritization will be determined. Now, in case of equal scoring system, then lottery or random selection is the way to break the tie. Now, when it comes to the fair allocation of scarce medical resources amid the COVID-19, in particular, there has been 22 articles published in PubMed. The first article that came and addressed this issue during the COVID-19, at the very early stages of the pandemic, was actually, perhaps most of you have read this article. And essentially, it summarizes the principles that I've alluded to earlier: maximizing the benefit, treating inhabitants equally, promoting and rewarding instrumental value, and giving priority to those who are worst off. But during the COVID-19 pandemic, I think it's very important to hear really what would lay people say. What would religion scholars or religion leaders say? Because, for example, in our part of the world, the religion scholars have a great impact and influence on individuals and on public perception of the different rules, regulations, even the lockdown, the prohibition of the prayers on Friday. These were much better perceived when religion leaders and scholars stepped into the scene. And then how would the views of lay people and religion scholars compare to physicians, to medical students, and to other allied health personnel? So we decided actually to take a step, and we approached the author of the second presented article and asked for permission to use the same tool that was used, the same survey and tool, in order to dwell into understanding how people would really think amid the COVID-19 pandemic, amid a real necessity and a real time where resources are scarce. And this is actually the article that was published I have to say that each and every name mentioned in the article have contributed significantly into the final stages and in seeing the article actually being published in the journal in our call. So we used the three scenarios of scarcity of medical resources. And interestingly, actually, one of the scenarios, even the one that was originally used by the paper in 2016, was about scarcity of hospital beds during a flu epidemic. And we looked into 5 groups: religion leaders, physicians, medical students, allied health professionals, and compared the views of all of these with lay people, lay individuals. And of course, we used the same 9 ethical principles and the combination that was originally used. And so these are, just a reminder, these are the ethical principles that were utilized, and we asked the participants to prioritize, to put with each scenario, which ethical principle would be chosen by them in an order from 1 to 9. So 1 is the most commonly or the most important according to their understanding, and 9 is the least important. And this is actually the demographic of our study. So in total, we were able to collect data from almost 750 participants. And this is actually our focus. It's scenario number 2 with a flu epidemic. And look at here, everybody, religion leaders, physicians, students, allied health practitioners, and lay people, they were all in agreement that sickest first is the principle that should govern the allocation of the scarce medical resources. This was followed almost by all groups by the prognosis, the survival, or the outcome, the anticipated outcome. Now, physicians and medical students chose combination criteria as their third allocation principle. But monetary and reciprocity, which is any good that has been done in the past, were almost not chosen by any, very minimally or almost negligible prioritization depending on monetary or service allocation. So although the original publication by Persad et al. Thought that sickest first principle was rejected because it was morally unjustifiable, actually people, whether it was the second paper or our paper, looked or confirmed that sickest first was the principle that was most commonly chosen by almost everybody, but in particular lay people. Now, in addition, when we did the analysis per principle, so the first analysis was per a group of participants. The second part of analysis was per principle. In general, there wasn't any major difference between allocation of the principles or the principles chosen versus the different groups. Only three that really stood out: that physicians tended to choose survival or a prognosis more commonly in comparison to lay people. Physicians were more likely to choose combination criteria in the second scenario. We're talking only about the second scenario in comparison to lay people, and they were less likely to choose sickest first as the prioritization principle in comparison to lay people. A very interesting addition that we did actually is that we allowed free text. So we had the space for the free texting and asked people to add comments, to add notes, and then we analyzed this part separately. Now, in total, there were 100 participants who added free comments, and out of these, 27% pointed out to a very important, what we call social value. And the social value, you know, in our parts of the world where often بيكون الابن, for example, is the main sponsor for or caregiver for the parents, his wife, the kids, sometimes brothers. مرات كتير ممكن يكون he is the only child. So actually many of the comments, 27 comments, specifically mentioned that an important principle of allocation that should be considered is the social value of the individual. Now, into the last question, can the same frameworks and guidelines work? So we know that, for example, in the UK, in the USA, in China, in France, there were different guidelines that more or less were kind of similar. But would these frameworks and guidelines really work in other settings? So this was our second paper when we looked into the allocation of the already limited resources amid the COVID-19 pandemic. And this is a very interesting table that we compiled. We worked on the table from different resources. And if you look into the number of physicians per 10,000 population, the difference between low and high income countries is almost 10 times, from 3 per 10,000 to 31 per 10,000. When it comes to nurses, it's almost the same. So it went from 9 per 10,000 population into 109 per 10,000 population. Hospital beds per 1,000 population. So 0.87 to 8 per 1,000 population. Again, almost 10 times. What about the ICU beds? And this is, of course, all prior to COVID-19. This is what is already on the ground. These are the resources that are available. So the ICU beds from 0.72 to 38.7 per 100,000 population. What about ventilators? So from some areas, places where we could not really find any documentation, any numbers. For example, in the low intermediate in Mexico, from around 2,000 ventilators into 25,000 ventilators that are present. And of course, this can all be explained on the basis of the total expenditure on health per capita, the differences between low and high income countries. But it's very funny when you look into the differences in the cellular force subscriptions. The difference is actually not that, it's not as much as 10 times or 50 times. It's only like double the number. The low countries have 50% the number of mobile phone subscribers in comparison to high income countries. So when we look into suggested solutions to overcome the scarcity of medical resources in low income countries or low resource countries, certainly those frameworks that work in other countries will not apply, because to start with, the resources that are available are already challenged and scarce. And I thought these are actually were the suggestions that we used and we advocate for in our paper. However, I would like to allude to that perhaps the most plausible of all suggestions was the mobile phone application. Since the mobile phones are not as scarce as one would anticipate in low resource country, then perhaps relying on and utilizing this resource in particular might help to bridge some of the gap already present in the resources that are further challenged amid the COVID-19. So the application using or utilizing mobile applications would allow for remote patient-doctor interaction, can help in training healthcare professionals, can help in following up on chronic diseases other than the COVID-19, and certainly can help in establishing, initiating, and maintaining consultation with experts worldwide. So in conclusion, I hope I was able to show for you how fragile the healthcare systems actually proved to be amid the COVID-19, and that the ethical principles for the allocation of scarce medical resources and the prioritization system can set the stage for fair allocation, but certainly ethicists are important, systems are important, but we have to hear the voice of our people whenever policies are being drafted and implemented. In our perhaps part of the world, and I'm sure perhaps I'm not quite sure if this really applies to other parts of the world, social value should be taken into consideration if allocation of resource principles are to be utilized amid a crisis time. And certainly it's not one size fits all. What applies somewhere in the world doesn't apply in other parts of the world. And with this, I would like to conclude my talk. And this is actually a portrait of the plague that hit London in the Black Death in London in 1349. And the quotation or the title of the portrait was An Unequal Blow. People on the margins suffered the most. This is unfortunate, but this is reality. Thank you very much for listening, and I hope my presentation was clear, and we'll open perhaps the floor now for discussion. Thank you very much.
Thank you very much, Dr. Maisa, for this wonderful presentation and sharing the studies, which I find amazing, actually. Regarding the unequal blows, I think this is the status quo of the worldwide these days, but we always prepare for the worst, but hope for the best, as we say. So just to be respectful of time, I'm going to open the questions for our colleagues. If you have any questions, you can either unmute your phone, your microphone, or type down your messages, and Diana will follow up on them.
Can I start?
تفضل Dr. Mahmoud.
Thank you very much. Thank you, Maisa. Thank you, everyone, for actually having this great presentation. Maisa, the assumption I've heard, I've written actually that the assumption is that this is done at a country level, you know, in an epidemic or in a steady state, like what we have, for example, in Jordan, pressurizing utilization of resources. However, in a pandemic, can you comment on the pandemic level where the countries that produce such things, the production sites, let's say the vaccines, the protective equipments, the medication, where these are really created first to the wealthy and then really come to lower income countries. I've seen your discussion really come down to a country level where, you know, physicians and maybe administrators and maybe policymakers have to decide what to do with the resources within that country. Can you comment on what happened at the pandemic level, where the masks were not really utilized in a very good way or sold to some countries, and then the vaccine now is being sold to richer countries. The same happened with remdesivir and others. Can you comment on that at the pandemic level rather than the epidemic level or the local city state?
Thank you very much, Dr. Mahmoud. أنا مبسوطة جدا إنك أنت معانا. So actually, I had a slide that alluded to what you mentioned. So in an ideal world, those fair allocation of principles can be applied even globally. And actually, for example, if we look into the WHO initiative, which is the COVAX, what they try to do is to help an equitable contribution of distribution of vaccine to countries that are less well-resourced in order to be able to benefit or to protect their population, but at the same time actually would add to the global defense against COVID-19. But this was, in an ideal world, COVID-19 vaccine would have been approved in some of the countries. They will start producing in large amounts. They would look into the most needed, or those according to the principles of allocation would score first places, will be prioritized, and then would give the rest of the vaccines, or will ship or will help the production of the rest of the vaccines to less resourced countries. So this was actually what ideally would have been wished for by everybody. But in reality, we know that 72% didn't happen, because around 72% of the confirmed active vaccines are being developed by private or industry developers rather than by I would say institutions, perhaps governmental or public institutions, that would really help in reducing the cost of the vaccine, and will help in further distributing an equal and equitable access to the vaccine. And we know that most of those developers are placed either in North America, in China, in Australia, and in Europe. And actually, there was a very interesting talk a couple of days ago on BBC. What they've said is that BBC reporter was able to get a hand on some documents that showed that well-resourced countries actually put obstacles in order to prevent the utilization or the manufacturing of vaccines in less resourced countries. So our wish list is actually completely different from reality on the ground. And the vaccine is a perfect example to what's really happening nowadays globally. The COVAX initiative that was started and initiated by the WHO, and again, I have here, I know because of the time constraints, I could not go over a good part of what I prepared for. So the COVAX tried to advise how to allocate, try to help less resourced countries to get vaccines, so that in phases, the initial phase would be for targeting around 20% of the population, specific targeting for, in particular, healthcare providers and those, the elderly and those with chronic illnesses. And then they would, the second phase, the priority of the vaccine that will be produced globally would be distributed to countries in which the healthcare system is really not well developed or under strain. But in reality, if we remember the map that I showed you initially on the status of the vaccine distribution and vaccination globally, actually the status is not at all what we wish for and what we dreamed of.
Sure, because
So,
COVAX and WHO has no teeth. Actually, their teeth is the
yes.
power, and there's no power. I'm
Yes.
sorry. That's all I am on saying. Thank you.
Sure. Thank you, دكتور محمود. شكرا جزيلا.
ميسا, I have a comment, Dr. Rami Al-Azab.
هلا يا رامي, تفضل.
كيفك ميسا? Thank you very much, but I think humanity failed again. I mean, after the 1918 pandemic, the superpowers started to prepare for Second World War, you know. But I have two questions that you did not tackle. One of this, did you control for in your study about the answers casted by mothers, females, males? Did you control for that? Did you have any input about this? Because I hope that we will not come to answer this very difficult question: who gets the treatment or not. My second point is that what's your take about the ethics or ethical consideration on making the vaccine a must, compulsory, that you don't have the choice of whether to take the vaccine or not? And do you think that this is ethical? Thank you.
Thank you very much, Rami. Now, actually, for the first question, yes, we looked into the differences according to the age distribution of the participants, according to the educational level, and according to gender. There wasn't any, apart from one, I think it was in the second scenario where males tended to choose random allocation more than females. But apart from that, there wasn't any difference into the demographic variables among the different demographic variables among the participating groups. So this is for the first one. Now for the second question, this is again very interesting because actually it seems that for a vaccination itself has its own what they call ethics or morality of vaccination. And there is a principle that is called in public health that is related to vaccines in particular, is the principle of the least restrictive principle. And what does that mean? If we take vaccination into example, that vaccines, ethics of vaccines passes into 5 different stages. You can start, first of all, by advertising for the vaccine. So there is it's just really what we're seeing nowadays in our part of the world, where people are encouraged in order to go and get the vaccine. And then you move into the second stage of nudging, followed by some incentives. So you would say, and I think people were starting to talk about what they call immunity passports. So those who are vaccinated can have the incentive of being able to travel from one country to the other. The fourth principle is actually penalty. So if you are not, you pay penalty, for example, if you were stopped by a health detector and proven not to have been vaccinated. Or another example is that kids, for parents who have not been vaccinated, will not be allowed to go to schools for face-to-face learning. It has to stay, for example, through online facility. And the fifth, actually, when still there isn't enough public response to vaccination, governments, policymakers can go into enforcement of vaccines into the public. And here really what comes into account is individual versus societal benefits. So you weigh whether the priority should be given to individuals and their autonomy versus the benefit of the society. And actually, there has been, again, nice articles. There is one book that is called The Ethics of Vaccination that discusses the various phases and stages of implementing vaccination programs. And a perfect example would be COVID-19 vaccination. So yes, a short answer to your question is yes. They can, governments can reach a stage at which they can enforce people to be vaccinated. Sure.
مرحبا ميسا، شكرا جزيلا على ال excellent presentation.
هلا.
بس أنا عندي comment أو let's say justification ليش ال vaccination rate was very high في دولة الاحتلال عندنا. هلا 50% أخذوا 2 doses و around 50% أخذوا 1 dose. So يعني تقريبا كلهم ماشيين في التطعيم. هلا ال ethics play a very important role. هلا فايزر كل اللي هنا في الإسرائيليين أخذوا فايزر. The reason is because Pfizer الإسرائيليين عندهم excellent health information system. So that was a big catch for Pfizer. يعني they wanted to know is their vaccines effective on 7 million, which is a very very big trial. يعني ما حدا بيحلم فيها. So they were given this data, but this data is the published data. لأنه كان في كتير question marks على إنه privacy للpatient. So what Pfizer got was the published, ordinary published data, which showed that the Pfizer is 95% effective على millions of people. هلا الشغلة الثانية, if you look at history, the Pfizer CEO, he's a son of Holocaust survivors. That also played a role. Plus إنه يعني هلا فترة elections للإسرائيليين, فنتنياهو was very keen on paying a lot and providing vaccines للإسرائيليين. Plus كتير بحسبوا هم economy is very important to them. So بحسبوا قديش الخسارة باليوم وبالدقيقة. Plus إنه كان عندهم high fines من أولها. الماسكس كتير بدفعوا. lock down كان very strict. هلا قبل أسبوع لما شافوا قديش في vaccines خلاص everything فتحوا. they opened up everything and people are back to their normal life. They're closing corona units in hospitals. فيعني you can tell قديش الethics يعني why Israel got all these vaccines للأسباب اللي حكيت لك إياها. it's very ethics are very important في كل شيء.
100%. Thank you very much, Nahid. And what I know for sure, yes, Netanyahu in particular played an important role. يعني he used his own personal relationship encounters in order to make sure that a population or the inhabitants of Israel are vaccinated. إذا بتطلعي actually هي أعلى دولة في العالم. يعني هم حطوا زي ما بيحكوا كل وزنهم. و definitely زي ما انت حكيتي having data from 7
basic data.
Yes. So هذه it's زي ما بيحكوا كل الدنيا it's the largest open clinical trial في التاريخ كلياتها.
Yes. Yeah.
بس هاي كمان أنا it's very important اللي انت حكيتي كمان.
Data.
إنه هم من data إنه كل إشي organized, so when they needed to use it, it's handy, it's in hand.
Yes.
للأسف.
ميسا معلش أنا لما صار الفاكسين الدكتور وائل هياج بتعرفي our all يعني he's friend of all of us. يعني إحنا we thought إنه people will stay in line to get the vaccine, but we are really disappointed from the.
Yes.
This is beside the point بس يعني.
Absolutely. احنا في البدايه كان الكل بيحكي وين الفاكسين، لما اجى الفاكسين بطل حدا بده ياخذ الفاكسين، بعدين لما خلصت اول مجموعه من الفاكسين رجعوا بيحكوا لك وين الفاكسين. فهم actually يعني مش عارفين شو بدهم. هم they're trying they cannot make up their mind. Actually they are more influenced by social media with rumors والاكثر كثير من science.
100%. Yeah. We have the same problem here in Lebanon and in many Arab countries. And I think, as you said, Doctora, the main reason is the swing effects of social media, which every now and then gives one information and then sends next day another contradictory information, so people are confused.
True. And of course دكتورة كمان شغلة كتير مهمة إنه بشكل عام our people don't read يعني ما they would not go and bother looking really for an evidence. ومظبوط مرات كتير الساينتفك evidence بيكون صعب، بس مرات بيكون في له abridged releases that are easy to understand، بس people لا they don't bother go an extra step in order to verify what was written.
Exactly.
بس كمان they don't have enough knowledge للأسف.
ما هي لأنه they're not well read unfortunately, and yes, exactly. Any other questions لدكتورة ميسا? Just to be respectful of her time, I know how she works at King Hussein Cancer Center from morning till evening, and I bet she would like to have some كنافة نابلسية and go to bed.
ما في هلا كنافة نابلسية، هيو
في
برا
في شيء رن الجرس.
رن الجرس علينا.
لا بس قبل بدل كنافة إذا بتريدوا.
So
thank you very much.
Thank you very much, Dr. Maisa, for this very interesting and valuable presentation. And thank you everyone for attending, and see you inshallah in our next Kawakib webinar.
Inshallah. Thank you very much.
Thank you, Dr. Thank you, Talia.
تحياتي.
Many thanks.
Thank you all.
شكرا جزيلا. Thank you.
Thank you.
Thank you all.